To the people in the audience, thank you all so much for coming tonight. It really warms, I think, all of our hearts to see so many people who are interested in this training path and all of the careers that are possible with it. We had our first of these panels highlighting some different people back in 2023, and I'm going to put that link in the chat so that people can check it out at a later time. And today we're super lucky because we have Brianna, Nadav, Rose, and Liz, who are all early career palliative care psychiatrists, and I think will really uniquely be able to share insights that are most up to date with what the current experience of pursuing this training path is like. So to our four panelists, thank you all for being here today. We realize it's a generosity of time that brings you here to share with others. And to the audience, we really want this to be as useful of time as it can be. So I am going to start by asking each of our panelists to respond to 3 pre-planned questions that I decided on for today. But from there, we're going to open it up to more free-form Q&A. So if questions come up, feel free to throw them into the chat. I was hoping that you'd be able to unmute yourselves and speak, but I don't think that that would be possible. So throw them into the chat, throw them into the Q&A. If you want to ask a question and you want to do it anonymously, I think you can do that in the Q&A, or you're always welcome to just message me directly, and I promise not to say your name. So with that, panelists, I'll start just by asking, how did you find yourself on this training path? What is your current setting? And what was the biggest worry that you had when you were choosing this path? Who's going to kick us off?
I'm happy to go, Dani. Hi, I'm Liz. And the reason I'm jumping in is because I was wondering, I don't know if the attendees know we can't see them at all. I was wondering if it would be okay if they put their name chat, because I would love to just see where people are from, and I'm excited to hopefully get to meet you guys in the future. My name is Liz Solklowski. I am currently at the Mayo Clinic, and I primarily work in the outpatient palliative care setting. I do not do like a shared psychiatry palliative care job. I do solely palliative care right now, and I think all of the panelists will probably agree there's a ton of psychiatry within just the palliative care setting. I primarily see cancer patients, serious medical illness patients. And so as far as my career path, it's a little bit different. I did engineering for about 10 years. I worked as a chemical engineer in Oregon, and then went to Oregon Health and Science University for medical school training and psychiatry residency, and then went to Duke University for palliative care fellowship. And the path, I always, I couldn't decide between internal medicine and psychiatry for the longest time. Then internal medicine would offer. I did meet with an internist at some point when I was trying to decide career paths, and they said, don't think about the super cool things about like the different career paths, because I really like the zebras in internal medicine, and think about the things you're going to be doing on a day-to-day basis, which was like blood pressure management and diabetes and things like that. And I was more interested in like kind of the unique things, and wanted to spend more time with patients, wanted to emotionally support patients and be able to have a lot of time to just hear what was going on with them and help them through suffering. I had a family member with serious illness, so that definitely influenced things. My biggest worry was that I thought I wouldn't have enough internal medicine training to go into palliative care. That did not turn out to be the case. And also just worried like about a palliative care fellowship. Would that be something that would be problematic, that I didn't have an internal medicine or family medicine background? And that wasn't an issue either. Dani, is there anything that else I need to mention? I think I got everything.
You got it all. That was great, Liz. And I didn't even know that you were an engineer, so it's exciting for me too to learn that.
Thank you.
I'm happy to jump in. Hello, everyone. I'm Brianna. If you hear some baby coos in the background, it's because my little one is eating right here. But I'm really thrilled to meet you all, to see your names pop up. So I came from a humanities background, loved kind of international studies, which is what I did my undergrad in, and kind of came kicking and screaming to medicine in that I felt like medicine was a really neat way to dive in social and more global inequities, and yet felt that like there was this like humanities piece of me, this narrative piece that I worried would get slightly diminished in the medical training. And I think that's a lot of the reason I came to psychiatry in the first place, is that I just really loved the whole person perspective of psychiatry, and the fact that I felt to be a good psychiatrist, you had to really understand what was going on for the person. And went to undergrad at Brown and then came back to Ohio for medical school and ended up at University of Arizona for psychiatry training, and felt that while I really loved getting to know my patients and that really helped me be a good psychiatrist, I felt that there was these other physical components that really added to suffering, and had a couple really interesting consults with the palliative team and loved that skill set of how they were able to kind of conceptualize whole pain, which was a concept I was really coming to on my own, but didn't have good verbiage around. And so ended up I didn't even know that psychiatrists could go into palliative medicine, so started kind of Googling who can be encouraged that was an option for me, and connected with some people that were at this intersection, really thought about consult medicine versus palliative medicine, and landed on the fact that I wanted a skill set to really address whole person suffering. And so then I just am finishing up my fellowship at UCSF. 3 more days, who's counting? And then I will start on faculty at UCSF in January, doing partial outpatient, partial inpatient consult position, mostly embedded in our cancer center for the outpatient work. And then have met Dani as my incredible mentor, and have been just so elated to jump into this world and realize there are a few of us interested in this path. I will really echo Liz that I was very worried that everybody who comes to palliative was internal medicine or family medicine. And I was worried that I would be way behind in my skills. I felt grateful that I think medical training has really evolved to allow us to do a lot of medicine in our psychiatry training. So similarly, I found quite the opposite, that the psychotherapy skills and the psychiatric skills that I had garnered in residency were over and over and over again called upon in fellowship and beyond. And so I'm feeling really grateful to enter this world and to
I'm happy to go next. Rose, I'll leave that the last spot for you. So I pretty from like I didn't know about palliative care before when I went into medical school, but we had a lecture in our first month, and I knew I wanted to do palliative care. And what really spoke to me was the existential issues, the anxiety around death and dying, there I had had some earlier experiences in my life that kind of like had like opened my eyes to the amount of anxiety there that can unfold unexpectedly around dying, and how lonely it can be, and how there really isn't any spaces to talk about it. And so the psychological side of it was what really drew me, and it felt so natural for me to go from to like choose psychiatry, and then go into palliative care. And I was worried because it wasn't a particularly well-worn path. And it's getting more so. So and we're here to represent that this is a thing that people do. And I was worried, similarly to Brianna and Liz, and probably Rose as well, because this is the way that like going into like a path where mostly internal medicine or family medicine people are going into, that I wouldn't have the medicine background. And I felt like entering fellowship, I was better prepared than any of the colleagues that I was working with, doing psychiatry and working with symptom management and dealing with things like, there's so much of psychiatry is palliative care. We're often not curing things. We're trying to manage things in creative ways. And thinking about them in both like psychological terms and using medications. It was like such a smooth transition. Um, I did my medical school and residency in Ohio, and then I was at Ohio State, so yeah. Um, and then I went to Cornell and Columbia for a fellowship, and then now I am upstate, about an hour north of New York City. I'm in a community hospital. I split my time. I'm part-time at a hospital where I split my time doing inpatient palliative care and outpatient psychiatry, and I'm also have a private practice. And I don't work any weekends, and I make my schedule, and I'm not on call ever, and it's definitely, it's not an academic setting, and I have a young family that's growing, and I'm able to spend time with my family, and it's really great. I'm happy to answer any questions about that.
It speaks to the multitude of career options that are open at the end of this training path. Right, Rose.
All right, I'll start with where I am. I just finished palliative care fellowship also at New York Presbyterian Hospital, so Cornell and Columbia's campuses at the end of June. And I stayed at Weill Cornell in a primarily research position. I'm a 232 postdoctoral research fellow. And then that's about 80% of my time, and about 20% of my time is as an attending. It's a clinical instructor, so not a tenure track position, but I do get to see patients as a part of that role. My research focuses on improving palliative care outcomes and delivery for patients with alcohol-related liver disease, which is actually the culmination of many of my interests, which is why I raised it. And that's something that I brought with me from my training in psychiatry. So now going all the way backwards, like Liz, I had a previous career before going into medicine. I was an evolutionary biologist and ecologist for about 10 years. Ultimately became unhappy with the position that I landed in and decided to pivot and go to medical school. I'd been a biology major in college and had all the prerequisites, so that was relatively easier than it could have been. I trained in medicine at Columbia's College of Physicians and Surgeons, and then did residency in psychiatry at Mount Sinai. I also was interested in both internal medicine and psychiatry when I was in medical school, did some research in infectious disease, but ultimately, as my colleagues have indicated, was drawn to psychiatry because it considered the whole person and integrated a lot of information about the patient, very carefully going through, what was going on outside of the patient in the home life, their development, their familial relationship, put together kind of a very complete, I would hope, picture of the patient to inform the formulation. So given those interests in internal medicine and psychiatry, I was very quickly drawn to consultation liaison psychiatry, and ultimately decided to do a fellowship in CL psychiatry, wherein I focused on transplant psychiatry. And what I noticed then in seeing patients at our hospital at Mount Sinai, where we saw a lot of very sick patients for liver transplant evaluations, I felt that if my goal as a doctor was to help patients, I felt like as a psychiatrist, particularly in those transplant interactions, I wasn't doing as much as I could. We'd see patients who we declined for transplant and then kind of didn't see them again. And to me, that was deeply unsatisfying. As someone who was making like a career switch, it was very important for me to feel like I was doing as much as I could. And I saw that my colleagues in palliative care were really able to treat the whole patient and to support the patients during difficult periods, as well as their families. And so I spent some time with the palliative care team at Mount Sinai, and then decided to move forward with a fellowship. And now here I am studying liver transplant and alcoholic liver disease. And my biggest worry, as my colleagues have indicated, was that I wouldn't have the medicine background that my co-fellows had, and that I would be at a disadvantage in that regard. But I actually found that I had a very interesting and diverse group of co-fellows. Someone was a general surgeon, someone was an EM doctor, another person was internal medicine. And together, we all had particular strengths and we all grew in different ways and brought something to our patients and had skills that we learned throughout our training. So in the end, I don't think that it was, ultimately a disadvantage.
Said this in the chat, but you guys are all so cool. It's very fun for me to get to hear your stories too. Question number 2 for you all. It's a 2-part question. So what would you say was the biggest challenge that you either encountered or are encountering? And what has been the biggest unexpected gift or joy that you've experienced because of this career path?
We can go in that same order again. Maybe it makes it easier. That's a hard question. The biggest challenge, I would say, is there's a lot of suffering. And sometimes it can be really heavy. And I don't know about my colleagues, but one of the things that I've noticed that has happened is that I get sent the people with the most complex psychiatric issues, and they also have all of the medical stuff going on, which is also kind of the biggest gift, because the suffering and wanting to be with people in that space is what I love so much about this work. And again, don't know about my colleagues, but I would say, like, follow your heart. I feel like these are my people in palliative care. We like to be in that space. We like to be talking about the very difficult things. I also have always been a kind of a firefighter, even in my engineering job. And I like when things are like falling apart and you get to be there for that, to like help people put things together as well as they can. Another thing that I absolutely love is that we work with an interdisciplinary team in a way that is just incredible. So, and I know this is not the case in every single setting. I feel very blessed to just like work with a chaplain, work with social work so closely. We work with psychologists in the psychiatry department. Sometimes we refer to the psychiatry department. One piece that's a little bit different is we don't have as much time to kind of see patients every single week. For example, if someone needs to have like psychiatric, interactions every single week to manage their psychiatric condition, then that, I think in that case, when possible, we refer to the psychiatry department. At the same time, mental health care is super short. And I often do find that I'm squeezing people in who I'm just like feel so connected to and feel like I really want to help. Have gotten to see like such very interesting things and how mental health issues coalesce with physical health issues. And I love what everyone said about the whole person, because I hate that we separate this like mental health, physical health. It's all one person, and then their whole family and ecosystem and environment. And we just really get to address all those things. And I could not be happier with this choice.
Thank you, Liz. That was beautiful. Yeah, echo all of those things. I think one of the big reasons I got into medicine, and what I was, I think, trying to help figure out throughout my education path, was just how to address and think about the inequities that we see in the world. And I think one of the biggest challenges is to really see those inequities play out as folks are suffering to such intensity, like the different placement options that are available based on insurance or lack of insurance, the way care is stratified based on, ability to pay, the racism that is baked into our system. And I think especially in this work, as we're partnering with folks as they're walking through serious illness and dying, we see those inequities kind of really in real time in a big way, and one can feel very small in the face of such challenges. And I don't know that that's different than other pieces of medicine. And I think that sometimes when the stakes are high and illness is really severe and someone may be walking towards dying with their families or sometimes alone, that can just feel very intense and one can feel small. I will say that I think with my personality, I would have felt that way in any realm of medicine. And so I do think that really does lead me to the next part, which is surely the biggest gift is just the ability to partner with folks. Like how humbly elated I am to sit in on people's most intense and vulnerable moments and be invited in despite just meeting someone. And I think this work, I don't ever leave a day thinking to myself, like, did anything happen, right? Like there is just such intense and tragic beauty in this work and in the ability to sit in the gray with someone else, be invited in, and be able to hold space for the people, for folks in front of you to share their beautiful wisdom that they have gained throughout their life. And I feel like I just get to like steal these little pearls that all these folks have garnered through their whole life. And I just get to sit in that and enjoy their wisdom. And so that has been a remarkable gift of this work.
I love what both of you shared. What what first came to mind was more practical and more focused on, for me, the biggest challenge was that comes to mind was when I was applying for residency, I put that I was interested in palliative care front and center, and people were not interested. Psychiatrists did not care. They didn't know anybody who had ever done palliative care from psychiatry. They weren't doing any palliative care work. And I found that I was like trying to express what I was so excited about and why it was so clear to me why I was doing it. And it really fell on mostly deaf ears. And that was really challenging for me to like try to figure out like how I was going to figure it out to, continue my path or like in the way that I wanted to. And then when I went into palliative care, everybody was interested that I was a psychiatrist and thought it was like the best thing and like was like so interested. So there was like it was that was a challenge and also really great. For me, I think this like the biggest gift is like I get to do all these things that I really like to do. And I get to mix and match these different career paths, and there's a lot of flexibility in that I see in the future that like I can shift things how I want to shift them in the way that works for me at that time and for my family. And I'm really interested in the future, hopefully, of like psychedelic medicine, and I think that will require doing private practice because it's going to be hard to do that in a hospital setting. So like kind of like building that out and being able to do that flexibly and trying to figure out how to make that my own. A really nice thing about being a psychiatrist is that I get paid as a psychiatrist doing palliative care work, which is just like a kind of like added bonus, at least in the region that I am. Psychiatrists get paid more than palliative care docs overall. So that's like kind of like a practical thing. And so like just like really the flexibility and like the amount, like I can see myself shifting from inpatient to outpatient and kind of like more in hospital or less in the hospital, and feeling really empowered in my work, able to do what I want.
I echo many of the challenges that my colleagues have mentioned. I think for myself, learning to, when I guess when I was doing outpatient psychiatry, there was kind of an amount of worry that I carried about my patients and that I took home with me. And I think now trying to navigate the worry and the concern that I have for my very sick patients, carrying that, how do I carry that type of worry with me? after I go home, and how do I manage the feelings that those encounters bring up for me. Um, but on the flip side, I think that sitting with patients and their families through these difficult moments can and does feel so honored to be a part of those interactions. And I've met so many truly wonderful people, and felt like I've been able to make a difference, I hope, for their lives and for their loved ones, that it's really given me tremendous joy, which is what I was hoping that it would when I made this career choice.
I resonate with so much of what you guys are saying. Last question from me before we open it up to the participants to ask questions. But if there was one concrete piece of advice that you would give to trainees who are considering this training path, or educators who are supporting trainees, what would that piece of advice be?
I think this is not super concrete. I'll follow it with a more concrete piece, but mine is just like follow your heart. Because when you're going to be doing your work for a long time, and do what you love, because that makes all the difference when you're working hard and staying late and caring for patients. Even though, I mean, I agree with some of my colleagues have said about, I feel like in palliative care, there's a lot of ambiguity too. We use a lot of psychiatric medications, which we know very well relative to some of our colleagues, and their side effects, which I also feel like we have a really good handle on. Meaning that it isn't like a blood pressure medication where it's like, you do this, the blood pressure is going to drop this much, we follow this algorithm. There's still a lot of living in the gray area. I'm totally going way beyond the question. I'll stop that line of thinking now, but a kind of like more tactical maybe piece of advice is what helped me is volunteering with hospice and also doing a palliative care rotation in my residency training, which wasn't a thing. I just kind of asked for it to be created, and the palliative care department was very open to taking a psychiatry resident. And I think that really allowed me to see like what the work was, and going, just deciding to just go for it. And despite not knowing people who had done this type of thing before. And I think that was really helpful.
I think that's great advice. I have heard over and over again, kind of find your people. And I think that is as true in palliative as anything else. And so getting an opportunity to spend time with palliative folks, to I similarly was able to tag on a rotation, and that was wildly helpful. And I think if this is something that you're interested in, just keep finding, like now you have all of us on this call. I think we would all be happy, and I'll speak for myself. I'm happy to field any additional questions or find ways that I can be supportive. But I would say just don't let fear get in the way. I think just continue to find what it is that motivates you, kind of find your purpose. And if this is something that seems interesting, just keep investigating. And we're here to kind of mentor you on that way, if that's it.
One thought is I think it's really useful to marry a psychologist. But if that's not an option, or that's not
too late for some of us.
Yeah, too late for some of you. I think it's it's good, a really supportive partner. Marry a supportive partner. That would be great. Really like find mentors. I think that for me, like in medical school and residency, like I reached out to the previous cohort of psychiatrists who did palliative care. I talked with probably 5 or 6 people. It's not that many people who are like acting as mentors, and it was so helpful. And it was through them and through my connections that I ended up in the fellowship that I ended up in. I'm sure of it. And I think that it was just really, it's really validating when I had questions that came up, and I was able to ask them. They gave me really good advice, and some of the advice was things like, try to do an extra medicine rotation, and that was useful, just like to answer like any questions when on the interview trail, in terms of like people expressing concerns about my medicine background, about that I had sought these things out. Doing an extra palliative care elective, like these were things that I heard from my mentors, and there's a lot of people in this. If you found this community, then you found people who are willing to be mentors. And so if you're interested, reach out, because as a group, we are interested in helping the next generation, or the next, it's not generation, it's just the next couple of years, you know, figure out what you want to do and help you along the way.
The next wave.
I agree with what everybody else has said. I think that if this is, or you're considering palliative care after psychiatry training, I think getting more experience in palliative care, as my colleagues have done. I also did a short rotation as a PGY4 in psychiatry, in palliative care at our hospital. It was also something that was like in theory, something you could do in theory, but not something that like people had done. So I had to advocate really strongly for it, but it was great. And it solidified my path moving forward. I felt very confident in my decision to apply for it, the fellowship, and to move forward with that career. And I agree, talking with others who have training in palliative care and psychiatry, and asking their advice and learning more about their experiences, as you're doing by watching this webinar. And I would, of course, be happy to answer any questions from folks who have them after this as well.
We've got some good questions in the chat, so I'm just going to throw them at you. Don't feel like all four of you have to answer every question, because we'll try to get through them all, and I will do my best to not chime in, because I plan to answer these too. So one question, is it possible to do part-time? What does salary look like?
I think a number of us do part-time, but I really do 3 part-time gigs. And it's definitely possible. You just have to find the system that is willing to do it. And I think that there's a lot of places out there. You know, when I was looking for a part-time job, I wanted to split my time, and I thought that it would be harder to find the palliative care side than the psych side, because everyone's looking for a psychiatrist. And so that's what I put out there. So, it wasn't hard. It wasn't, for me, it wasn't particularly hard. I don't know if that's going to change. You know, there's different waves of ease of getting jobs in different areas. But definitely possible, and definitely, you know, you have to figure out what your priorities are and what things you're willing to be flexible on. And then I think you'll be able to be successful in that way.
I will add to that and say yes, definitely yes, because I'm one of the only people that works full-time in my department, and I'm going to part-time next year. And part of it is the finding your people in palliative care, and largely because of our patients know what is important in life. And lots of times work is not the number one thing. And we learn that from our patients. And so I think there is a lot, just the culture is to kind of do what feeds you and focus on what is important in life. And then the other piece, salary wise, from the patients or places that I interviewed where I was aware of like what the psychiatry salary was and what the palliative salary was, either palliative was higher or they were pretty much the same. That's kind of what in an academic setting.
Yeah, having just kind of forayed into the job market, I will say that I was really interested in a position that would allow me to do both, like both psychiatry and palliative, because like a lot of the folks on this meeting, I really like psychiatry as well. And I found a lot more openness, not exactly the question you asked, but in bigger academic centers to be able to partner those things. I found it harder in private practice or in like bigger hospital systems that were not academically affiliated, unless kind of, as Nadeeb was saying, you're doing multiple part-time jobs, but I did find a lot of receptivity to part and part. And so I am doing a full palliative job, but hope to transition into more psychiatry as time goes. And kind of similarly to Liz, looking through kind of FTEs or thinking through full-time work, piecing them together was actually quite similar salaries, at least in the academic world, which is mostly what I kind of focused on. And so the salary didn't look that different, but in at least in the psychiatry realm, one can make a much higher salary in private practice than academia. And so taking that into account, thinking through the salary.
Do people want like concrete salaries? Is that like, I know it's like not comfortable.
I think it also varies so much geographically. You know, what you can ask for in private practice in San Francisco is unthinkable in other cities. But if people do want that, let us know in the Q&A and we can maybe find a way to share that. But let me, because there's more questions. One person is asking about palliative psychiatry and sort of making the distinction. There's like palliative care psychiatry, which is psychiatrists who are caring for patients with serious medical illness and have their whole psych background. And then there's this concept of palliative psychiatry. Can we take a palliative framework to psychiatric illnesses themselves, which is actually a really hot topic. And right, and can there be a terminal psychiatric illness and things like that? But would any of you be able to speak to this in actual practice from your experience? All right, I'll jump in. The only thing I will say to the person who wrote this question is I have some colleagues who are in this palliative psychiatry space. A lot of them got formal palliative care training. I think it's so helpful. Some of them didn't and have self-educated in the concepts of palliative care. I think it's very cutting edge for us in psychiatry to really think about psychiatric patients from this lens and what is our goal. Is our goal to get their voices to go down, or is our goal to really holistically think about their quality of life and things along those lines? But for those of us who train in psychiatry and are practicing in palliative care settings, palliative care hasn't really experienced much palliative psychiatry yet. We're not, with the exception of the rare anorexia case that causes a lot of intense feelings for everybody, we are not seeing a lot of people whose primary illness is psychiatric. Not to say that we don't have a lot of amazing colleagues who are doing awesome work in this space. And so if you shoot me an email after the session, I'm happy to connect you to some of those people who are primarily practicing psychiatry with a palliative lens. Although, Nadav, you could probably, since you have a psych practice, maybe comment on if your palliative training is impacts the way you conceptualize your psychiatric patients.
I feel they inform each other. I don't think that's like would be like people who are coming in and they're struggling with things. They're often struggling with grief, or they're struggling with their own limitations or physical limitations or things that have happened. You know, I feel comfortable in that death and dying space, and I feel comfortable with serious medical illness. And so, you know, I think it definitely comes up. And
Dani, this is a total tangent for a sec, but if anyone's interested in like medical ethics, that's another place that's very common in palliative care that I really love, kind of the psychiatry piece too. And those anorexia cases come up on the ethics committees in the hospitals for sure.
All right, we have a question that says, can you share any examples of how your psychiatric training has helped in managing complex emotions in end-of-life care? I'm sure you can share many.
There are so many. It's really hard to even like narrow it down. It's almost every single case. There is a distinction that I feel like we don't learn in psychiatry about the distinction between depression, demoralization, and grief. And so there's a lot of like working out that kind of stuff. Demoralization being like, my life has no meaning. What is the meaning of life? Lots of times that happens kind of towards the end of life for folks. And so I feel like we do a lot of work in that space and just kind of, figuring out what is going on with the patient. PTSD is another thing that is quite common, and just kind of sussing that out, because I think, and I won't go into a lot of details because I think it could take up a lot of space in terms of examples, but a lot of our patients have symptoms that look fairly similar. And I think we have a lot of experience in terms of kind of separating out exactly what is going on with the patient and what are the interventions that can be most helpful from a mental health perspective.
I think I'll also say just one of the things that comes really naturally, I think we get a lot of in psychiatric training, is kind of thinking through a formulation, thinking about the person in front of us and the characteristics that make them them. And then thinking through things like boundaries and frame that can be really helpful interventions, especially among populations with certain characteristics and personality types. I think this is a type of patient that we see really be challenging to a lot of our colleagues from other specialties. And I do think that the psychiatric training has allowed interaction in really therapeutic ways that also help replenish empathy. And I, again, kind of think through that formulation and frame with every patient I see, similar to what Liz was saying. But I think some of those really challenging, more personality type presentations can get even more exacerbated in the setting of serious illness and death. And I think we have a very particular way of thinking through those. And I often talk with my internal medicine or family medicine colleagues about how I'm conceptualizing, putting up, thinking about boundaries or thinking about therapeutic interventions. And I hear all the time, I wish we had language for that in internal medicine. There's like a lot of thirst for that information. So that's been really, really.
Right. Another question for the panel. Do any of you have experience with providing psychiatry services catered towards grief and loss outside of your work in palliative care?
Yeah, I think if you're having outpatient psychiatry practice, you're going to be doing things in that area. And if you're looking for it, it's pretty much everywhere. So, I do have experience with it. I think there's a lot of, it's a rich area. I think that there's a lot of growth and there's a lot of opportunity there as well.
This is possibly irritating because it's not answering the question because you specifically said outside of our work in palliative care. But one thing that we haven't mentioned that I did want to bring up is that I feel like we get to be secret psychiatrists in palliative care sometimes. Like there's so many people struggling with their grief, struggling with their loss that would never have been sent to psychiatry. And yet they really benefit from the psychiatric skills and knowledge and therapeutic presence that we're able to bring. And that's been a very joyful part of the job. But next question from the panel, it says, I was wondering if you all could speak to the breadth of jobs available to psychiatrists with palliative training.
I don't know. I'm curious to know what this person is curious about, like, because there's inpatient and outpatient and private practice and academic and rural and there's just there it's all over the place. I don't even know what the limits are, because when you're a psychiatrist, you can do all kinds of things, and when you're palliative care, you have like this additional skill set, which kind of opens you up to all kinds of different things. So that doesn't seem to be an answer to the question, because I don't know. I don't even know what the limits you're concerned are.
I also think like things like psych-onc or embedded psych clinics, like there's a lot of things this pathway can take you to outside of even what we spoke about today. At the last panel, you guys can listen, Sam is a psychiatrist who did a palliative care training, and he's a hospice medical director, right? Which I think like speaks to the fact that you have all of the things available to palliative care doctors, you have all the things available to psychiatrists, and then you have this creative space in the middle where you can create like Dan Shalev, he's dual trained and he has these embedded clinics and he's doing research on those clinics, and you can create spaces in the middle and hybridized spaces in the middle. So it does feel a little bit endless. I'm sorry, panel, I'm answering your question. All right. Thank you for taking the time for this panel. I'm August, an MSc in Ohio State. I wanted to ask if you had advice on how to best identify and advocate for yourself when pursuing rotations, other opportunities that may be more rare in traditional training. Good question, August.
Since I went to Ohio State, maybe I'll answer that one. I mean, I'm not sure. I found that the palliative care department was very open. I did a rotation at Riverside, which is another hospital and they have like a standalone hospice. I did a rotation. I did an inpatient rotation with the palliative care department. I did an outpatient rotation with the palliative care department. I was there for a long time, and I knew I was going to do palliative care for a long time. So I tried to get a lot of exposure, and there are a lot of different I think, all the advice, which was like get involved in a hospice or kind of like have experience with that, and get experience with the palliative care department. And the Ohio State palliative care department is very large and it's growing and it's very open, and there are some really amazing clinicians there. I don't think they have any psychiatrists, but they have a lot of people that are interested. And now the psychiatrists at Ohio State should be aware that people go from psychiatry, because I was there.
I'll add one thing that is like partly coming from an old person like me. But in my first job, I attended this like career development thing as an engineer. And the thing that somebody said, which always stuck with me, which has just held to be true, which is if you want to do something, tell people. You just got to talk to enough people and somebody is going to help you. If you keep it to yourself, it's just not going to go anywhere. So talk to people and tell them what makes you passionate, and someone will latch on and help you out.
Did any of you struggle? I'm jumping onto the panelist questions, but did any of you struggle with timeline? In my residency, fourth year was where the electives lived, and you had to have applied before then. Was there a lot of advocacy needed for that?
I actually oh, go ahead, Rose.
I think it's possible, although I don't regret ultimately doing a CL fellowship, given where I've ended up. I was not able to do the palliative care rotation until I'd already matched into CL. And I do wonder sometimes, had I done it earlier in my PGY 4 year, whether I would have foregone CL and just gone directly into palliative care, given how strong an experience I had.
I ran into a similar issue as you, Dani, in terms of the electives really being in fourth year. So I really kind of planned ahead of time, even into my second year, that I wanted my palliative rotation to be the literal first rotation I did my fourth year. And so I had technically sent out all my applications. I had spent time with the palliative department best I could in between consults and things, but my first real experience was after I had sent those applications. And I always felt like I could say no to any interviews that came if I hated it. But I think there's also something to just kind of diving in and then getting experience you can. So I think really early planning and advocating, and I think like we've said here, is just finding people who are down to mentor you, especially within your own program, whether that's your program directors or the folks in the palliative department, just finding ways to make it work. And I think Liz said it so beautifully, just keep telling people this is what you want and be creative about how to.
We have a couple people who are asking, I'll read both questions. One is curious about any resources, books, readings that have been helpful or resonated for you, both in terms of day-to-day in the field or some of the larger questions that come up. And somebody else said, any recommendations for books or articles that have helped you in your care with patients, especially with existential and spiritual questions and crises? don't even know where to go with this
Um,
album. Where are you going to go?
yeah, so I think that there's a lot of stuff out there. One author and psychiatrist who I really like is Irvin Yalom. And he wrote a book about existential psychotherapy, which is really great. He's written novels which kind of reflect on um, different things related to death and dying. He wrote a book called Staring at the Sun, which is really great. That was all about working with patients who were struggling with existential issues. Um, so if there was one author, or I would say Irvin Yalom is fantastic.
I'm literally looking through my book list right now. I think there's a lot. Maybe we can email.
Maybe we'll send a
Yeah.
follow-up to the participants. There's so many, like Harvey Chachanov, if you're thinking of the papers, has so many great papers in this space. I understand that Brianna, who's here today, is writing a chapter about demoralization, death anxiety, loneliness, things like that. So there's a ton, but why don't we work on pulling together some of our favorites from the paper space and book space, and we can try to send it out to you all as a follow-up. Okay, next question. How did you prepare for the fellowship? Getting experience, learning about the role, showing interest? We've kind of talked about this one. I would say we've talked a little bit about doing the things you need to do to know that you want to go into fellowship. I think preparing for the experience of fellowship, you don't need to. The same way you send your kid to kindergarten and they don't have to read yet, like just show up and they'll teach you what you need to be taught. And then but I do want to say that Carly Zapata, who's our training director here, at the last panel, somebody asked her, what if I can't get an elective in palliative care? Like, is there something I should do? And she highlighted this piece that you brought up, which is showing interest. And she said, find a way to show me that you truly have an interest in this, that you've done enough of your own due diligence that I'm not concerned that this is not your calling and you're just coming to me anyways. And she said that could be anything. You can find any way to do that, but just make sure that there's some way that you're able to communicate that to a program. So next question. I may need to move in a few years as my partner finishes their PhD and was wondering if you recommend waiting to start fellowship in the location you may live longer term to help improve connections and chances of finding a position in academia, or would you try to start a fellowship knowing that you may need to move within 2 years of finishing it?
I think in medicine, we always have a reason to put our life on hold. So I'll just say that out loud. I'm sure that this is really dependent person to person, but I will also say that, I would trust your intuition on what is best. I think a lot of us end up staying in the circles of places that we trained. And I think the net is really wide and there are lots of connections from people who have, been at that training program that end up somewhere else, or, the job search, a lot of people end up in a place that is not where they trained. And so I would not say that that is a barrier to going somewhere and getting your life started if this is what you really want to do.
I will tag on to that and just say again, as an elder, that your life will wind up in places you never imagined. And it is just, probably Rose agrees with me that you just kind of follow your passion. I think you can get a job anywhere. So if you want to do the fellowship straight away, it's totally fine to switch jobs later.
I would agree. Don't hold off. I think for the connections and logistics of finding a position, there might be a different reason to hold off for family or other reasons, but I wouldn't have that be it. And I will say things have changed. Like when I was in training, Stanford wouldn't interview a psychiatrist, and now they have 2 psychiatrists, on their staff, and they're all about psychiatry, but things have changed. And I know, when Liz was applying for jobs, everybody was like, oh, she's a psychiatrist, try to get her. And we felt the same way about Brianna, and we did get Brianna, but I think we're pretty coveted right now in the palliative care world for good reason, and that's pretty amazing. So next question. I love this person for saying y'all. I'm going to read it the way you wrote it, whoever says y'all. To the extent that y'all are comfortable, can you talk about the pay range in your city and the pay difference from working in psych academically to Pally academically?
I mean, I'm not working academically, so maybe I shouldn't be the first person answering this question. But for for my hospital, a full time position for a psychiatrist is 300,000, and and I get paid a prorated rate of that amount as both as a psychiatrist and a palliative care doctor. Um, and yeah. um, and so that's what it is. It's great, and I don't think the palliative care doctors, for the most part, get paid that much. When I looked, I used a I used Resolve, which was a online lawyer thing to help negotiate my salary, and through them, I got access to all the de-identified information about salaries across like the the contracts that they're negotiating or whoever they're being connected with, and overall psychiatrists get paid. I think the average was psychiatrists in the high between the high 200s and the low threes, and then palliative cares were low twos to high twos, which is what I saw as the averages.
But for those of you in academics, does it feel like there was a big distinction in the pay or pretty similar?
I feel like it was very, very close. Now, if you're a child psychiatrist, different ballgame. So you're going to make more money in academics too. But I feel like 220s to 270s, something in that range, kind of depending on where you're living and cost of living and all those sorts of things.
Talking to a couple academic programs about a dual position, and this isn't exactly what you asked, but the reimbursement per FTE was the same. It was just kind of like an academic reimbursement. And again, these are kind of bigger academic centers that were willing to marry the two, but I will say that there wasn't going to be a big change if I did more FTE psychiatry or more FTE palliative. It was kind of exactly the same numbers. I think the numbers that I've heard are really consistent for what I've been seeing in academia for either of those.
Okay. Next question, it says, are there any aspects of psychiatry you still miss? If so, what and why? And I'm going to jump on my soapbox for a second to say, I think many of us truly conceptualize palliative care as our psychiatric subspecialty. And so I get this question a lot, and I'm like, well, what do you mean? I'm a practicing psychiatrist every day of my life. But with that, I think we know the spirit of what you're asking, and I will open it up to the panel.
I guess
Oh, go ahead.
the work that I do with patients now is in a purely palliative care setting. Although, as my colleagues have mentioned, there's a lot of overlap. What I mentioned, or what I missed last year, and I'm continuing to miss, is being able to think about my patients psychodynamically and to think about what their unconscious motivators might be and their drivers, and to formulate them in that way, and then to have a supervisor with whom you can kind of devise a plan of care for them. And that's something that I've really missed, is kind of getting to think really deeply about what's motivating and driving my patients and oftentimes their families.
Rose, I do process rounds with our fellows, as Brianna knows, and we formulate and then think about how do we use that formulation to treatment plan, but we're thinking of making it a more nationally open thing. If we do, I'll ping you so you can formulate with us. Anyone else missing pieces of their psych training? I love the look on your face, Liz. It's sort of like, no, not really, pretty happy.
And that is so true. This is like almost like a horrible answer to the question. In psychiatry, sometimes in outpatient clinic, you can see someone fairly frequently and you can have an easy-ish visit. I feel like, so it can be more chill sometimes. I feel like I don't see my palliative patients as frequently in outpatient clinic, and it's almost like a new consult every time because so much has happened medically with them in between. So there's just a level of complexity that sometimes I find that it takes a lot of time, which I enjoy, but it sometimes could have been easier in outpatient clinic.
Okay. For those of you who were also drawn to CL psychiatry, what helped you decide on palliative?
I think there is a lot of overlap between the two fields, at least is the way that I conceptualize them. But for me personally, it was very important that I feel like I was doing the most that I could. And when I was working in CL, or doing the most that I could for my patients, and when I was working in CL, I felt like I wasn't doing as much as I was capable of to really help my patients. I felt like there was a lot of suffering that I wasn't touching in my work. And I felt like palliative care was a means by which I could learn the skills and then ultimately practice in a way that I could just help my patients as much as was possible for me. And that was really what I was seeking in this career.
Panelists, I was so enjoying listening to you that I dropped the one moderator ball of watching the clock. We're 3 minutes past. So I'm gonna thank you for your time, and thank you to the audience. We will send a follow-up with some resources. We'll think about that together. You might get a survey from me. We just want to make sure that we're hitting everybody's needs and really here for you all as mentors as you traverse this journey. We are here. Reach out to us anytime. So cool. With that, thank you, everybody.